It's our pleasure to welcome you to the February Health Outcomes Seminar. Today, it's our pleasure to welcome Dr. Karen Farris from University of Michigan. Dr. Farris is the Charles Walgreen Professor of Pharmacy Administration at University of Michigan School of Pharmacy. She also serves as the chair of the Department of Clinical Pharmacy and also serves as director of the pilot grant program at the University of Michigan's Clinical and Translational Center. Dr. Farris's research and teaching focuses on social theories to examine how individuals manage their medications and also the roles of pharmacists in influencing medication use, including public health issues. Okay, so as I say, she has a tremendous number of publications, also extensive funding, focusing on medical adherence and some of the other areas highlighted. Today, she's going to talk to us about medication adherence. Welcome, Dr. Farris.
Thank you. It's great to be here. I really appreciate the invitation. I know several people in the room. I don't think I have to stand by this device so that you can hear me. Is that correct? Okay, and I guess I should just confirm, can people online hear me if I stand here? And somebody's going to tell me if somebody types. So I'm going to move forward. Yeah, okay. Thank you. Thank you. I appreciate it because I cannot stand behind that podium and drive me nuts. So I'm going to talk to you today about the 5W1H of medication adherence. So it's just a different way of getting us to think about what we do in medication adherence research. So in my slide deck, let me just give you the heads up. In my slide deck, I have two studies that I would love to talk with you about. But let's be real honest, I have a feeling I'm going to get one done. Because number one, I get a little excited about it. And then number two, I would love to hear and have some input from you guys about some of the things I'm thinking about. I've already had a great conversation with Dan this morning. It's given me some great ideas. So I have a feeling we'll just get through one of them. And my husband said to me, I was telling him my dilemma. My biggest dilemma yesterday was how many slides I had. And he's like, Karen, I really hate it when speakers have 50 slides and they only get to 25. It's like they're cheating me. And I'm like, well, they'll be all right. They'll be fine. So don't feel cheated, okay? Don't feel cheated. When I get to come and talk to different folks, we can talk about the second study if I don't get there. All right. So this is what I want to try to achieve today. Particularly, I'm definitely going to talk about one prospective study that we're finishing, and then I would like to talk, if possible, about one that I'm planning. And I have a medication adherence model that I would like to get your input on. So we're going to have a little bit of two-way conversation as well. So I'm just going to start you out with this model. So take a look. You know, we're theoretical. We have to have models. So this is a model that I put together based upon some of my work, based upon looking at other health behavior models. Clearly, there is not a line in every box. But what this model is saying that a person has to have the meds available. They have to have the capacity, the cognitive capacity, the psychomotor capacity to take medications. They have to have the motivation or intention. So clearly that's coming out of social psychology literature. But then they can be really motivated. They want to take them. They can take them. And dang it, they just can't remember. Now, there's some data that make us think that remembering may have some belief components to it. I've got some data that support that. But certainly we know when we look at the adherence literature, about 50% of people report forgetting as the reason they're not adherent. I don't fully believe that. I'll just be honest with you. But we definitely need to be thinking about cues and strategies, cueing strategies that we can use to help people remember. So then from my perspective, that leads to adherence. Am I taking the drug correctly? Okay, am I taking the drug as I should be? That's adherence. So then I get some result. I get an improved blood pressure. I get an improved A1C. I get reduced depressive symptoms. I may have an adverse effect. So I may have to harness some coping strategies to manage that adverse effect. Over time, taking your meds correctly leads to persistence. And that's what this model is saying, which ultimately leads to long-term outcomes. So my first question to you is, what's missing? And I got a couple ideas, but what's missing? What's missing? Anybody have thoughts about it? Sir, you've got to have something. He's an economist. Try to pick an eye.
Availability can mean a lot of different things.
Okay. So I've got cost, shortages. Are there other things that people think about?
Availability of pharmacies.
Availability of pharmacy, so geographic distribution could be an issue. If you're rural, urban, does that make a difference in availability? Yes?
Social stressors?
Social stressors. So I agree that's missing. What I hear you saying is that really this is a personal model, right? And what's missing is what's the family structure, what's the social structure in which this individual is making decisions about medication and medication taking. So I don't think this model fully gets at all of that. It does to some degree, perhaps in coping, but I'm not sure it's as explicit as it could be around remembering, around other support strategies that family, the environment could offer an individual. So I think that's missing. Yes?
I mean, there's something about the complexity of care in general that they're facing, and there's some kind of feedback onto that. In real life, if you don't adhere, then you get worse, and then it gets more complex.
Right, okay. So,
I don't know how
okay.
you add this diagram.
Well, I think part of it's there in that you try to take your meds, you have short-term results that aren't quite there, that goes back, and it's going to impact whether you think the drug is the right thing to take, whether you think your treatment regimen. So I think it's going to impact that motivation and intention. However, I also think I heard something else, which is this medication use model sits in a much larger context of the person's whole health, right? And so they may be managing a lot of other things besides medications, which impact capacity, intention, ability to remember, and short-term outcomes. And I don't think that's reflected there. So I'm going to move us on from this model, but I just wanted us to begin to think about, this is the way I think about adherence and approach it, and want to write this paper about this model, but yet I know there are things missing, so I'm actually going around and talking to people about it and trying to figure out how we can get it more complete. That said, a more complete model is really tough to test, and it's really tough to test. I'll leave it there. All right. Okay. So if I step back and I think about studies generally in medication adherence, we've got studies that go from one medication to a drug regimen, which could be thinking about number of drugs. We've got for a disease, so I've got heart failure, I need all these drugs on board. I've got a person with 3 chronic diseases, therefore I got 10 drugs on board. So we have studies across that range. But then we also have medication studies that are beginning to focus on specialty medications. So the what is, who knows, right? It can be one medication, it can be one disease, it can be one entire regimen. So I'm just saying, when you begin your medication adherence study, it's important for you to think about what is your what. So funny. Okay. What is your what? Okay. Why do we study medication adherence? Why do we study medication adherence? I would assert to you that we really don't need that many more studies that say non-adherence is a problem. Okay? Anybody think we need those? I'd be happy to hear somebody think, maybe on a new medication, brand new medication, particularly if it has a particular adverse event profile. So I'm not saying we never need to do those, but we know it's a problem. Let's stop doing those studies and quantifying just for that. So let's move on and let's think about The next studies we need to do are to understand the reasons for non-adherence. Why are people not taking their meds? And then when you know that, you can develop interventions that help address those reasons, right? And you know you've got to match those, right? We don't give an adherence aid to someone who doesn't think they need their antihypertensive medication. And we all know that cognitively. I'm not sure we always think about that when we're working with a patient. We're like, we're going to give everybody an adherence aid. We're going to give everybody motivational interviewing. We're going to give everybody some combination of that. And we need to be thinking about tailoring. Understanding patterns of non-adherence. So I'm sure some of you are aware of some newer work, say in the past 5-8 years, that have looked at different patterns of non-adherence. So the classic example is somebody's really great at taking their meds Monday through Friday. And then on Saturday and Sunday, they're kind of off the wagon, so to speak, because it's a different day, right? Their schedules are typically not the same, not always, but that's one pattern of non-adherence. So I think that there's still some interesting work that we could do around patterns of non-adherence. All right, who? So this is, I've already had this conversation with Dan, and this is among my favorite topics. Well, when we do studies about non-adherence, we want non-adherent people to be in the study if you're doing an intervention study. And I'm going to show you some data about how horribly difficult it was for me to recruit non-adherent patients into our study. And you can judge whether you think we were successful or not, because I don't think we were. So be thinking about that. How do you recruit non-adherent people into your studies? And then when I give you a break here in just a few minutes to tell me, I'm going to write down all your suggestions. All right. How do we know if someone's non-adherent? There's a gazillion ways, quite a few ways we measure it. Self-report, PDC from claims. You can get electronic bottle openings now. At the person level, we can look at blood levels. There's some new technology around pill tracing. I haven't used it. Anybody in this room used it? So like when there's a chip in the drug, you know if the person's taken the drug. I think there's several now. I haven't used it, but it's out there. Okay, where are we talking about non-adherence? I think many of us are thinking about it, certainly in the ambulatory setting. So it's in the home, but health plans are concerned about this. Increasingly, some of our physician offices and organizations may be concerned about it. When do we think about measuring non-adherence? I have up there that our goal is to have unobtrusive daily monitoring. We would love that. Okay, I would love that when you see the intervention that I have. So what I mean by that is the patient has to know I'm monitoring it, but I don't need the monitoring to change their behavior. So that's what I mean by unobtrusive. Okay? They still need to know. Okay? I'm not saying they don't. I'm not saying it's secret. Okay? But I don't want them to have to change their behavior, and you're going to see how I made people change their behavior just to measure it here in just a minute. All the way up to yearly claims and maybe the pill tracing and those kinds of things. So we have this wide range in adherence. So this slide was just to say it's kind of all over the place. And that's fine. Okay? So there's a lot of opportunity. So what I want to talk about now is this study called AIM at BP. And it is artificial intelligence medication adherence testing for blood pressure. I worked hard on that acronym. AIM at BP. Okay? AIM at BP. Look how cute that is. It's nice, right? Yeah. Yeah, a marketing person. That was a marketing person. Okay, I didn't hire her to get this done. But she worked for one of my co-investigators. So it was easy smeezy. So it's good. AIM at BP. All right. So let's use the 5W1H for this study. So real quickly, we're looking at one antihypertensive medication, not one drug, but a person who has one. And that's all we're monitoring is their one drug. Even if they have three, we're monitoring one. Okay? We're testing the effect of a reinforcement learning guided text messaging system. So reinforcement learning is a form of artificial intelligence. We have an agent, and we'll talk to you about that here in just a sec, that sends out messages. and we're going to test if those messages are working. Who do we recruit? Here's part of the kicker. Persons in a health plan who had a PDC less than 0.5. Or so we thought. Okay. Or so we thought. So that's what the claim said. The claim said PDC less than 0.5. So you're like, less than 0.5, these people have got to be non-adherent, right? Just wait.
And over what period?
A year before, okay? All right, so how are we measuring it? We're looking at self-report. We are looking at PDCs, although I'm scared about that data. And we've got electronic pill bottle openings. Where's the adherence going on? It's going on in their homes, but we're partnering with the health plan. So this is also data for the health plan. And what are we doing? Here's your favorite word, obtrusive daily monitoring, okay? Obtrusive daily monitoring. We've got baseline 3 and 6 month self-report, and we will have PDCs once we let enough time pass and we can get more data after the study. So we've just wrapped up the study here in October. All right, here was our objective: to apply reinforcement learning to develop a medication messaging system, more or less. We have a randomized control prospective trial. We wanted to recruit, it's a pilot study, 25 people into each arm. Okay, that was our goal. We're partnering with a health plan in Western Michigan called Priority Health. And you can see the inclusion criteria. So a person needed to be texting already. Okay. So this wasn't something new we wanted to bring to them. And then I've already talked about the adherence measures. So this is an example of a reinforcement learning agent. So an agent, that comes from the engineering world. So just beginning this conversation with engineers was fascinating. I am not an engineer. They have a different language. They are all good, but they have a different language. So just getting to figure out how we were actually talking to each other instead of past each other was fun. It was fun. So we have this agent. So in Karen's mind, in my mind, it's a set of formulas. It's a program. And it sits and it says, I'm going to look at this data. I've been programmed to send 1 of 5 messages to you. This person right here in the red shirt. And I'm going to send some messages to Edith. I'm going to send some messages to Glenn.
I want some, so we'll have cultural literacy.
I can send some messages to Stephanie as well. Okay? And before it sends anything, it has some state data about you. It has some data about you that we collected at baseline. So we know your age, your gender, we know how many meds you have, we know your concern beliefs, your necessity beliefs about your antihypertensive medication from the start. Because that's some state data. It's telling us something about you. Okay? So the agent has that data and it says, oh, I'm going to send you a necessity belief message. I'm going to send you a concern belief message. I'm going to send Glenn a reinforcing, oh, you're doing a great job, go Glenn. Okay, that kind of message. All right? That goes, so that's the action. It goes into the environment. The person who gets the message sends a reward, positive or negative, in our case, back to the agent. So I send you a message, do you open your pill bottle? So that's basically what I have here. So I needed electronic monitoring daily, and it's obtrusive, and I'll show it to you in a minute. It's not unobtrusive, which is what you want. All right, so I send you a message, you open your pill bottle or not. That serves as the reward, irrespective of whether it's positive or negative. I send you a message, you don't, that's still a reward to the agent. So reward doesn't mean good. Reward just means a signal back. Okay? Does that make sense? Okay, so it just means, did my message work? Work meaning you opened. All right? Now, you're all saying, well, what if you open the bottle 5 hours later? Or what if you opened it 15 minutes before? So that's all about decisions. Even though this is an adaptive approach to messaging, there are still deterministic things that we set up in this agent. So we said, I send you a message, the opening is in the next 24 hours. That is the reward. If it happened 10 minutes before, don't care. That one gets attributed to the previous message. We had to set up some rules. Is that a problem? Maybe. Okay? Over time, the agent, we can add state variables that say, of the last 5 concern delete messages I sent you, what percentage of them worked? And you can add this new variable to the state. Okay, so you can use data from the agent to create new state variables. So over time, the agent is saying, I am trying to improve the probabilities that I'm sending you a message that gets you to open, and I learned that from you. Okay, I learned that for you. But it also says, you know, I need to try this other one just in case it's also going to work. So it will also continue to test other kinds of messages, even though it knows you've been responsive to 1 or 2 times. Okay, so that's where the adaptation comes from. It's sending you what you know works, but continually trying to figure out what else might work. Okay? Have I been mostly clear? See, I get a little excited. I know. This is the whole system that we set up. It's a little complex. What it says on the top, on your right, this is my right hand, yeah, on your right is the messaging system. We had a bank of messages that it would choose from. Down here is the engine, the RL engine or agent. Here's a web interface that our researchers needed to use. Here's where the messages were sent or sitting. And then this is, actually I lied, RDEX is where we got the pill bottle openings. I said that was the messaging. That's the pill bottle openings that we were getting. And then here was the messaging. Okay. Here is my obtrusive reward. Okay? So a person had to take their antihypertensive medication that they got from the pharmacy. They had to put it in this little vial right here. And on that vial, we considered this an adherence aid from a legal perspective. So we didn't have to label it like a prescription. Okay? So the patient, because I'm a pharmacist, and I'm like, oh, what are we going to put on the label? Okay? So we treated it like an adherence aid, and it had the patient's name, it had the drug, and how they were supposed to take it right off of their label, and that's all it had on it. Okay? They would take their medicine, put it in the bottle, put on the lid, and then every day they would just take their medicine out of this bottle. But to send us the data about whether it was open or not, it's captured in the MEMS cap, which is right here. And when we started this study, the technology was such that, at MEMS anyway, the sensor wasn't in the cap. That's not exactly true. The sensor to know if the opening was in the cap, if it was opening or not, and when it was opening, what time it was opening, all that was sitting in the cap. But the technology to send it to me had to be in this little coffee cup holder thing right here. That's what I called it, because it was about this big. And it had to sit beside somewhere in their house, and they had to take the pill bottle and turn it upside down, set it on this reader, and then the reader would turn blue and like do a little circle, do a little dance, and then they would know that the data had come. So they could do that every day. They could do it once a week. If they were traveling, that's fine. They just took their bottle with them. They didn't have to take their reader with them. Okay? But eventually we would get the data, and then we would populate what had happened to that person. But the agent is still making a decision every day based upon the data it has as to what kind of message it sends you. Okay? Any questions about, so if you think about behavior, they had to move their drug. And then they had to do this pill bottle upside down thing. That's not normal. That's not normal medication taking behavior, right? So I'm being obtrusive. I'm like right in their space. So that's not the best measure. There are some better technology now where the information to the cloud sits right in the cap, which is where we need to go if we continue. Okay, any questions so far? So exciting, right? Yeah, be awake. So good. Okay, so these are the 5 types of messages that we created. So you can see they're based upon intention, which was comprised of, do I have this condition? Does it need to be treated? Do I think these medicines are the right thing for me and that are working? And then what concerns do I have about these medications? Okay, so we set all of beliefs, necessity, and concerns theoretically in the intention and motivation perspective, okay? And then we had remembering strategies, and then we had rah-rah messages, okay? An option for the agent was to send no message, okay? So actually the agent every day made a choice between 6 options. 1 message or no message. Okay? And why would you put no message in the loop? Think about if I have a text messaging program, why would I put no message as an option? You're a user. Think about it like a user. Yes?
You don't want them to start ignoring it because they're getting tired of getting it.
Exactly. So you want to try to keep it fresh. That's a silly word. But if you send them a message every day, they're just going to be like, all right, here's my med message, whatever. So you're trying to get the content of messages as well as whether they get a message varying so that they can, in theory, stay tuned to your messages. Yes?
Can I ask a question about the phone number that the message came from?
Mm-hmm.
Was it?
Came from.
So, yes.
From us to them.
Yes. So did it come as one of those 5-digit codes, or did it come as a phone number with an area code full set?
Well, I am 99% sure it came from a phone number
Okay.
because they would respond to us on occasion.
Okay.
But it's possible it could have had a name to that,
It did not, I'm pretty sure.
Well, just
Mhm.
thinking, like you said, like
Like a user.
So sometimes you get like a random text message
You're
with a
right.
5-digit number. Oh, you entered this.
Right.
Versus if you see a real phone number, this
Right.
means that there's a person behind it.
Right.
There's an organization
Yeah.
behind it.
Yeah, that's a good point. And I don't know if we put AIM at VP on it, in retrospect, you're like, duh, why didn't you do that?
Or if they even saved it in their contacts so they know.
I do know that when we enrolled people, and there's a whole discussion we can have about how we enrolled people over the phone, because in our first trial of N=20, we had face-to-face visits, and in this trial where we went to the RCT, we enrolled them over the phone. And so that's a whole nother issue about how we did that. But we definitely had them, they had to have their phone there. If they got randomized to the text messaging group, they got a text message right there when we had them on the phone, so they knew what they were going to get. So just FYI, but I still think that there's some other issues that you bring up that we could have made it more user-friendly. Yeah. Good question. Okay, so these are our 5 kinds of messages. Let's see. Okay, this just tells you, this is a study that we did before. Yeah, you're like, that's not a study. That's a heat map. Okay, that's a heat map. And it's showing you sort of 5 blocks. Okay, so here's a block you can see. This is a block. This is a block. This is kind of a block, but not so good. And here's a block. So we took our messages, and we took a sample of our messages. We got people who are staff at the university. We also did a group of pharmacy students, and we said, here's your messages, put them in buckets. And we wanted to see if the way they thought about the messages was the way we thought about the messages. So if I say it's a disease belief message, did they think that also? Okay? So what this is telling you is that the disease beliefs and the necessity beliefs for medication are a little muddied. When the box is red and clear, there's strong agreement. Okay? So this was just an approach we used where they were sorting the messages. They put them in buckets. They labeled the buckets for us. And so we did this one round. We changed some messages and did it a second round. Okay, to try and we were really working on these messages. And we got better. It's not perfect, as you can see. Okay, so here we go, recruitment. So we had 1,100 names of people from this health system who had a PDC of less than 0.5 for their antihypertensive medication the year before. So you would think these are non-adherent people. Woo! It's gonna be good. Okay? So you phone them or you send them this letter and then you follow up after you've sent them the letter, okay? And so what you can see is 748 people, we called them 4 times and we couldn't get to them. So, are they non-adherent? Sure. Do they just not want to be in our study? Sure. Do they go to the University of Michigan? Crazy liberals on the east side of the state? Sure. Yeah, I made that part up. But this was on the western side, which does tend to be a little different than the eastern side. So, but, like we couldn't get to them. Okay, so there's a big group of people we couldn't even get to. Okay? So then among the 233 that we could actually get to, you can see ineligible, refusals, and consented. Okay? So, and this took a really long time to get 49 people. At least a year, I think longer. It was so painful. And I think everyone in this room that's done a prospective study will say recruiting is among the most difficult things you do. But I, even as old as I am, was like, if I get this list and the PDCs are less than 0.5, like, it can't be that hard to get people into this study. Well, clearly I was wrong. We had an incentive, so how do you recruit non-adherent people? If we could answer that question, we would be famous. All right. So here's who we have in the study. So I probably didn't make this clear. I didn't make this clear until right now. Everyone in the study got the bottle. Okay, so everyone in the study got the bottle, the electronic monitoring. The thing that we were really testing were the messages. Okay, so we're saying what's going on with adherence among people who got messages. And how is that different from everyone from the group who also had electronic monitoring? Okay, is that clear? We do not have a group of people who had no electronic monitoring. Okay, we do not have that. All right, so in terms of age, race, education, income, health literacy, those were not statistically significantly different. What you should look at is I used a one-item self-reported adherence from Lou, which comes out of the HIV literature. Overall, how would you rate your ability to take your medications in the past month? Excellent, very good, good, fair, poor. I did not bring a whole lot of data to show you why I selected that question, but I can talk with you about that. So you can see the percent excellent. Yeah, not so bad. Among these people who have a PDC less than 0.5. So if we say percent excellent and very good, it's even more. So at the beginning of the study, we were screening actually on this question. And if someone said excellent, we would let them in the study. We might have got 10 people in the study over 6 months. I'm serious. I was dying. And so I said, We're going to relax that, and we're taking anybody who will agree to be in this study, because in theory, their PDC should be telling me something about their non-adherence. Okay? It's still a little painful. So, but look at the PDCs. I'm telling you what they are right there, 0.38, 0.41. And we all know self-report is not the same as a PDC, is not the same as a pill bottle opening. But we got a problem with the claims when a PDC is 0.38 and the percent who say they're excellent is 70. There aren't that many people buying them. So Dan and I were talking about it this morning, and we went to the free drugs at Meyer. Paul knows about those. There are going to be $4 prescriptions in many of our organizations. And when we were talking with Priority Health about who we wanted in the study, we actually excluded 2 chain organizations because Priority Health said, quote, they don't submit their $4 prescription. Okay? So, again, we had this assumption that then other pharmacies were submitting them. But I would suggest to you, clearly they are not. Okay? So if you're thinking about running PDCs on these widely available drugs, I don't know. There might be a problem. Okay. So data today include the one item, self-reported adherence, and I have some pill bottle openings, but up front we have not done the statistical analysis on the pill bottle openings yet. Okay? So this is showing you the one item self-reported adherence where 1 is excellent. We coded it 1 is excellent. And you can see, based on the data I've already shared with you, everybody's pretty good. So that says, Karen Farris, how in the world are you going to move adherence? It's already pretty dang good. How do you recruit non-adherent people into a trial testing non-adherence interventions? I don't know that we do. That's sort of my new revelation. I think we just put them in the wild and measure them from an observational perspective, which definitely has its issues too. Okay? All right, so here's the data at baseline 3 months and 6 months. This is the difference between baseline and 3 months, baseline and 6 months, which is what we're more interested in. There's the 3 and the 6 month there as well. And then we did statistical analysis on these different scores. And it's still like preliminary early data, okay? So these are the different scores. So we have a statistically significant change in improvement. It is an improvement at 3 months. That is not sustained at 6 months. You can talk to me about whether that's clinically meaningful. I get that. Probably not. Okay? So from this, I would conclude the text messages improved self-reported medication adherence at 3 months, but not at 6 months. Okay? So this is important from an RL perspective. So what this tells you, and it is tiny, I apologize. Look at the colors, okay? The colors are what you need to be thinking about. So the blue is no message. The blue is no message, and then the other colors are the 5 other types of messages, okay? So when we began messaging people, we set them up to look like our baseline data. So if their concern beliefs were high, we sent them concern belief messages for the first couple of weeks. So the first 2 weeks, we set the messages. We deterministically, okay? We set them. Then we release the agent. Okay? Then we let it begin adapting. So you can see at 3 months, it's preferring no messages, and in 6 months, it's an even greater preference for no messaging. So what that's telling you is that that's working. It's working. So we have adaptation, which from an engineering perspective is important. It's learning to send different messages to different people over time. we, in theory, believe that would engage individuals to a greater extent than sending them the same kind of messages all the time. Stephanie?
Were the patients able to text stop messaging at any time?
They were not.
Wow.
No, we were mean.
Oh.
We did not. Now, if they wanted out of the study, yes.
Yeah.
If they called us and said, I want out of the study, then that's different than saying stop sending the messages. Nobody said that. I will tell you though, which is a little problem from an IRB perspective. So in our pilot study of N equals 20, I'm trying to remember in this study, but we had 2 people who wanted to stop receiving messages because they were making them anxious. And they wanted out. Because we were raising, we're sending them concern relief messages. If you're having this kind of side effect, talk to your doctor. If you don't treat your blood pressure, you're going to die. Okay, it didn't quite say that. Okay, it didn't quite say that. But disease belief messages are about you have this condition, here's what it's going to do to you if you don't do something, right? And the medication necessity messages are about you need to take this medicine because it's going to help you get here. Right? So some of the messaging among some individuals cause anxiety. So we can say this isn't going to hurt people. I got a small amount of evidence that says, yeah, it did. So for a larger future trial, that's got to be taken into account in my mind. Okay, so our agent adapted. Okay, so you're going to say, Karen Farris, she was so funny. All right, so if it's green, so what these data are like the straight up data from the treatment and control each person, okay, for the 6 months that they were in the trial, okay? So we average their openings, okay, we average their openings for the month. If it's green, they open every day. If it's red, 0.35, 0.5, it's pretty low. If it's yellow, it's less than 1, but still really good. Okay, it's still pretty good. 92, 90, 80, this is 89, 85, here's a 64, it's between the red and the yellow. So you can see overall that the treatment group definitely has more green. The messaging group has more green. There's more perfect adherence from pill bottle openings. But you should also say, Karen, you need to look at what those other numbers are and figure out if some of that yellow should be green. Okay? To be fully upfront, these data came from my engineering person 2 days ago, right? So I couldn't phone him and say, okay, if it's 80 or above, it needs to be green. I didn't have time to get that done. But I'm being upfront with you. Green is 100. Okay? So there are other really good adherence numbers in the yellow, is what I'm telling you. Okay? That's what it is. Okay, this is feedback from participants. Is the frequency of messaging right? So if you think about the 23 people that were in the messaging group, 18 said it was about right. We did this at 3 months and at 6 months, and they continued to say it was about right. But think about what no messaging was doing. No messaging was going up. Remember? So I think the adapting is a very positive component here, and people aren't so annoyed with so many messages. Does that make sense? And I can get at the data about how many messages were going in and out. I just don't have it right this second. When we asked them how many messages a day they wanted, you can see the breakdown here. Around 8 people said once a day, every 2 to 3 days, and then once a week. This is interesting. We asked them if this kind of service was available, would you enroll? And the number stayed at 10 at 3 and 6 months. So 10 out of 23 would enroll. So I think there's some percentage of people, not quite half, who value this type of adherence support. Okay? Okay, so what can we really say? Text messaging worked at 3 months, but not at 6, and we had obtrusive monitoring. Okay? The adaptation of text messaging also worked, but I've got to do a little further digging and understanding about the number of messages that were still going out at the end of the study, and I just haven't got there in terms of the analysis yet. Okay? You can see 1 message per day or 1 every 2 to 3 was generally preferred, and about half would enroll again. Okay. So, oh look at question 3. You have heard me say that a few times today. So in this study, to recap, 1 antihypertensive medication, we were testing the effect of a reinforcement learning guided text messaging system. 2, we had adherent people in the study, even though we didn't want them, because they're good already. How do you recruit non-adherent people? How did we measure it? Self-report PDC bottle openings. Where were we? We were in the home. In the health plan, my contention is that the data were poor. When I've let enough time lapse, so I need about 3 or 4 more months to go back to the health plan and get more claims, then we can look at and align the pill bottle openings with the same time they had what was going on in the claims. Does that make sense? But I don't have that data yet. We got data before the trial started. I need to let some time elapse, then I'm going to go get the data after the trial started and for a period after it. Okay? When we got to figure out how to get around obtrusive daily monitoring. Okay. I have a whole other study I could talk about, but look, I'm right on time. And so that's what I knew would happen. So, what other questions do you have? Yes?
Did you assess for any potential difference in either messages that were sent among patients that downloaded their device more often or less often than the other patients? Because I would be curious to know if the decrease in messaging was for patients that hadn't downloaded for 2 weeks. Because you said it was based on the last 5 occurrences or openings?
Yeah. Yeah.
It
wasn't just, no, it wasn't the last 5 openings. The new state data that were generated were out of the last 5 concern messages, I sent you what worked. Out of the last 5 remembering messages, what worked. Okay, so it wasn't quite that. But it's a good question. So the protocol, for lack of a better word, said, put the bottle on the little spinner every day. Well, of course, people didn't do it every day. And from the agent's perspective, it took data when it got it. So if you were gone for 2 weeks, you were still opening and closing. And when you came back and you put the data on, then it began to use that new data for you. But that's a really good question about whether there's this notion of changing messaging and if that affected what people were doing, if it was impacted by people sending us the data on a more frequent basis. I don't know the answer. It's a very good question. We can get at that. I just don't know it. Oh, one more, and then I'll come back to it.
Another question on the green was
Yes.
in the beginning and shifted more toward yellow. Do you think that there was the development of dependence that the patients had on the incoming messaging? And if the messaging stopped after a while, do you think that potentially there was a link there that they started to rely upon that and didn't have as much, or that if there was any influence there?
That's a good question. So your point is that over time, we know the messages adapted and became less frequent. But what we also see in the messaging group is increased non-adherence, at least as defined by not 100%. Right? That one's I almost didn't show it to you, but I just decided to show it and then disclaim what I think some of the problems are in it. So that'll be something we need to look at. You guys are so helpful. Yes?
Did you look at baseline at all to see if patients were excellent or actually excellent? Baseline.
Well, according to their PDC, they were not excellent. According to PDC, They were 0.38, right? So they're not excellent. But what you can see is that in month 1, they're all pretty good, right? So one might think we should limit our analysis to month 2 and afterwards, because in month 1, everybody's being great because they know they're being monitored. And over some time, you're gonna kind of forget it, but because the behavior is obtrusive, I'm not sure about it. So while I think we have a cool intervention, it's got some issues. Other questions?
It would be interesting to have a run-in period without any.
Yes,
And
yes.
get the baseline data available.
Yes, and so we thought about that, but we went with the PDC data. And we were like, these people are gonna be non-adherent, or not great. The PDC was less than 0.5.
The problem with that, though, is exactly what you said. A lot of times you give people those monitoring bottles,
And they get better.
virtue,
Yeah, yeah.
for a short period of time.
Yeah.
I mean, I hesitate. I don't like it that you're saying we can't identify patients that are non-adherent. I don't
No,
want
no,
people to
no.
hear that.
No, we can identify them.
Yes.
Can we get them in a study?
Okay.
So that's those are 2 different issues. Sorry, I wasn't clear.
Well, where I misunderstood.
Okay.
But the other thing, this is really impressive to me that you were able to do all this by the phone.
Mhm.
If you were in clinic, that face-to-face contact makes recruitment so much easier. So you didn't do yourself a favor by recruiting this way either.
Well, so I can hear that. Although when we were in Ann Arbor, it wasn't a lot better. So I think in Ann Arbor, we sent out a couple hundred letters, and we got 10%,
Well, so
which is a little better,
but when they come to the clinic, I know this is super expensive, but the way we've been able to do it here is being in the clinic, and
Right.
the patients come to the clinic recruiting them there.
right,
It probably equals out though, because how many letters you have to send out.
right. Right. So the thing about recruiting, we did have someone within the organization with Priority Health that was at least saying, will I consent to be in the study? Okay, within that organization. But then all the baseline and us randomizing them and all that, we did, and we did that on the phone as well. Like we mailed them the materials, got them on the phone, went through everything. Yes, final question, I think we have to be done because the class might be coming in.
Okay, just really quickly, maybe there might be time. I noticed in your demographics that the mean income was pretty darn high in this population. Is that just an artifact of this health
Of the health plan, yeah.
Okay.
And I think the fact that we have a health plan
Yeah.
with this, and this is a private insurer. So we weren't in the Medicaid program. Dan was talking to me about, that might be a population that's better. We talked about people taking oral oncolytics. We talked about being in an integrated health system. So there are certainly some other things to think about, and if an agent like this could be useful. But I'm just trying to think about what's that next grant that can get it done. I'm being honest. Where I can be successful, not necessarily successful in saying text messaging help, but just successful in running the grant, in recruiting, in getting the messaging to work, I'm not saying successful showing what I want to show, what I hypothesize, but just in making it work. I'm concerned. Based on this experience, I'm concerned. Okay, we have to end.